in San Diego for my fellowship was I went very specifically to learn pulmonary rehabilitation with Dr. Reese and Ms. Trina Linder. And so for me, the idea that pulmonary rehab even 15 years ago was a huge focus for how we're managing patients. I'm sad to see that in 2015, it's still not the foundation for how we manage our patients going forward. Meaning it's an afterthought. And I think the sad part about afterthought is that when I get my patients in pulmonary rehabilitation, they're already disabled. Hard to take a patient who's already in a wheelchair and find a quality of life that they would find to be more beneficial. We do, and I think that's the thing that most patients, if they come to rehab, will find, is that even if they were disabled at the time of evaluation, they get some benefits still. And I think if we can find these patients earlier and get them in sooner, we're going to start to affect the unfortunate loss of muscle mass. As soon as you're hospitalized, you start to become weak. As soon as you start to become weak, you start to lose muscle mass. And not getting out of bed, and that's why in hospitals now we're getting everybody up early, is that we're trying to prevent this process of muscle mass loss. And I think the idea for pulmonary rehabilitation was that we would wait until patients felt better. And we now know that's not true. In fact, within 4 weeks of hospitalization and discharge, patients should be referred and directly sitting in front of a doctor like myself or any of the other clinicians who do pulmonary rehabilitation so that we can start affecting the disease course. Because I think when we talk about number needed to treat, everybody's familiar with number needed to treat, being number of patients needed to treat in order to prevent one bad outcome. So number needed to treat at 4, I don't have a medication on the market that does that. I can prevent one hospitalization out of 4 by making sure they went to pulmonary rehabilitation. And mortality, 6. Number needed to treat of 6. All right? And so for me, these are very low numbers. These are numbers that suggest that when you have the right patients, every patient with lung disease is appropriate for pulmonary rehabilitation, not just you. But when you affect that disease by providing patients the means to become more physically active, by increasing their exercise capacity, you really can change not only the quality of life of that patient, but the mortality track of that patient as well. Is that my moment? I got a little bit more for you. Let's see if I can get that clap in the next episode. But I think exercise starting early, as I mentioned, reduces the need for comfortable decline. I think that's the problem that I have, is that so many of my folks, even when they come out of the hospital, have declined to the point where they don't want to get off the couch. They go home, they sit on the couch, and they get worse. And I think that's the sad part about being discharged from the hospital with a qualified diagnosis of COPD exacerbation, is if you don't get up and active right after, and I'll show you that on the next slide, then you're not likely to do well. Actually, it's not the next slide, but I'll point that out to you when we get to physical activity. But I think symptomatic patients with any degree, we now recognize patients who are just smokers. Just smokers.